Assalamu alaikum. I am Dr. Atif Raza. This is your pediatric learning channel, Paeds Mentor. In part 1, 2, and 3, we have discussed the approach to neonatal cyanosis, the lung pathologies which causes cyanosis, and the cyanotic congenital heart disease. You have ruled out all these three. You have done the work. The chest x-ray is clear, so you rule out RDS. The echocardiogram is structurally normal, so it can't be TGA, hypoplastic left heart syndrome, but the baby is still blue. So the question is, what did you miss? Because the most dangerous blue babies are the ones where the heart looks fine. Today, we cover the hidden killers, the disorders of blood, brain, and the great hidden killer that is sepsis. If you stop thinking after a normal echo, these babies will die under your watch. So, let's start with the blood, that is hematological issues. Because sometimes oxygen is present, but the blood cannot deliver it. Here we are discussing three main hematological causes that can lead to cyanosis. Starting with the first one, that is polycythemia. Second, we will discuss methemoglobinemia, and the third one we discuss in this lecture is anemia. So, starting with the polycythemia. Polycythemia usually means the blood which is thick, having hemoglobin in more concentration, having hyperviscosity, with a central hematocrit greater than 65%. So, when the hematocrit is greater than 65%, it means the baby is polycythemic. And why it causes cyanosis? Because the blood moves very slow through the capillaries. The tissue extracts all the oxygen, leaving desaturated hemoglobin behind. So the look of the babies are plethoric, deep red, purple, not just blue. So, mechanism behind this: baby is polycythemic. So, blood moves slowly through the capillaries. All the oxygen which is present over there extract by the tissues. So, when the oxygen is being extracted, hemoglobin becomes desaturated, and the look of the babies are plethoric. So, baby look plethoric. So, what's the treatment of this? Treatment is basically hydration. So, we hydrate the baby, and if symptomatic, like the baby is having seizures or having a stroke, then partial exchange transfusion. The second one, after the polycythemia, is methemoglobinemia. The chocolate cyanosis. This is the classic board question and a terrifying bedside trap. Here, the iron is oxidized from ferrous to ferric. In methemoglobinemia, iron is oxidized from ferrous to ferric. And we all know that ferric can't carry oxygen. So, what's the clue? How can we identify this condition? There must be some saturation gap. Pulse oximetry usually rates 85%, but the ABG-PaO2 is normal. So, here pulse oximetry reading is approximately 85%. And when you do ABG, the PaO2 is normal. This is because the oxygen is dissolved in plasma. It's just not binding to hemoglobin. So here oxygen is present, but it cannot be carried by hemoglobin because the iron in hemoglobin is oxidized to ferric form, which is not able to carry oxygen. So pulse oximetry shows oxygen saturation of 85%, but when you do ABGs, it shows normal PaO2. So whenever you find this condition, that is pulse oximetry reading is approx 85%, that is less than 90%, and ABG's PaO2 is normal, always think for methemoglobinemia. And when you draw the blood looks like chocolate brown, and it does not turn red when shaken in air. So here the blood is chocolate brown. So this is also called as chocolate cyanosis. What's the treatment of it? Treatment for methemoglobinemia is methylene blue. We give methylene blue approx 1 to 2 mg per kg. Now comes toward the last hematological problem, that is anemia. If you gone through the lecture number 1 of this series, I have told in the lecture 1 that you need reduced hemoglobin to look blue. So if a baby has hemoglobin of 4 gram per deciliter, they may be profoundly hypoxic but never cyanotic. They will be pale, white as a sheet. So do not wait for blue to treat shock. So here, remember one thing, these babies are usually pale because we require reduced hemoglobin at a particular level so that the baby looks like blue or cyanotic. But if a baby has a hemoglobin of 4 gram per deciliter, they might never look cyanotic because let's suppose if a baby has 4 gram per deciliter of HB, it never look cyanotic, but it can be profoundly hypoxic because it can't reach to the level of desaturated hemoglobin to show cyanosis. They will be severely pale. So, do not wait for blue to treat shock. Here, you should start to transfuse packed cell. Now, after these three, came to the second one, that is the brain. Here we are dealing with CNS along with metabolic. Sometimes the lungs are fine, the heart is fine, but the drive to breath has crashed. Means the baby is hypoventilated or having apnea because of issue in CNS or either the metabolic pathway. So if the baby isn't breathing, saturation start falling. So when the baby is in apnea, that is breathing is stopped, sats start dropping. You have to treat this like just like the PALS protocol. Now the second one, that is seizures. Neonatal seizures are subtle, bicycling, lip smacking, and sudden desaturation. So look for these signs, that is bicycling, lip smacking, and sudden desaturation. Treat the seizure with the seizure protocol. Third one, which is metabolic. If a baby is hypoglycemic, that is hypoglycemia, as per Gomela, hypoglycemia can cause apnea. So, hypoglycemia can lead to apnea, and apnea led to cyanosis. So, if a baby is cyanotic, always check their blood sugar level, and we have a goal to keep blood glucose level above 45 to 50 milligram per deciliter, and if it is below this, we give 2 ml per kg of 10% dextrose. Now the third one, the great imitator, that is the sepsis. This is the last part of the entire 4-part series of approach to neonatal cyanosis. This is the monster, the one that hides in plain sight. So we call it the great imitator. Sepsis mimics everything. So it can mimic as heart disease, just like shock, acidosis, and poor perfusion. It can mimic like lung disease, that is pneumonia or PPHN. So remember the rule. In neonatology, you are never wrong to start antibiotics on a blue baby. You can stop them in 48 hours when the culture reports are in your hand, but you cannot undo delay. So, give ampicillin and gentamicin to all babies who are cyanotic and wait for the result of cultures. If the cultures are negative, you can stop it, but you cannot delay to start antibiotics. If you have a blue baby with a normal echo and clear lungs, suspect sepsis immediately and start antibiotics. So, now this is all about the approach to neonatal cyanosis. Let's close the entire 4-part series. This is your mental checklist to remember. Start with the look. Look for acrocyanosis or central cyanosis. Then test. Test for hyperoxia. Give 100% oxygen and then check for PaO2 in ABGs. If it is less than 150, suspect heart or PPHN. Then looks for chest X-ray. If it is ground glass, think for RDS, and we have already dealt with the heart shape, boot shape, the other one egg on a string, and the figure of 8. If you want to know what are these three, check the approach to neonatal cyanosis part 3. And the final one is echo. Echo is for TGA, TOF, HLHS, and other congenital cyanotic heart disease. If you have done all these, but still you can't find any of these reasons, think for the great these three, that is blood, that is the hematocrit for polycythemia. Hematocrit is greater than 65%. Color of blood, if it is chocolate, think for methemoglobinemia. Pale, think for anemia. And if all the things are normal but the baby is still blue, think for sepsis. If you follow this logic, you will never panic. You will save the life systematically. This concludes our detailed approach to neonatal cyanosis. I will start another series like this on neonatal seizures. So, if you have any query, you can ask me in the comment box. But remember, these all lectures, all approach series are only for educational purposes. If you have anything in your mind, consult your consultant or doctors. Prepare your own ward guidelines. Till next video, Allah Hafiz.